Good morning, everyone. My name is Joe White, and I am a clinical faculty member at the Opus College of Business here at the University of St. Thomas. I'd like to thank our business partners, Clifton Larson Allen and Frederickson Byron, as we welcome you to this morning's Future of Healthcare webinar. Thank you for joining us. Before we get into today's session with Dr. Asplin on the prescription for a successful partnership, I would like to cover a few logistics. This would have been our 13th year holding the annual Future of Healthcare conference. However, of course, we are moving to a virtual format instead of a full day conference. And our plan is to deliver one webinar a month over the next 5 months or so. Giving you the same content that we hope will help you in your careers and learnings about what's happening in healthcare. Our next webinar will be Friday, December 11th, when we will be welcoming people from Best Buy and Mayo Clinic, Sheila Krochek and Jared Mueller from Mayo Clinic, Sheila Krochek from Best Buy Health. They'll present an overview of how their organizations are creating new innovative strategies in order to enter new markets, build internal agility, and expand their reach. It should be very interesting to hear how Best Buy Health is approaching this. After the webinar today, you'll receive an email with links for the recording and the presentation deck and a registration link for our next webinar. It might take a couple of days for that to come out, but watch for that. For our agenda today, Dr. Asplin will kick us off with a brief presentation, 20 minutes or so, I think, but we're flexible. And then we'll enter into a Q&A session. I'll be joined by Dr. Tom Patno, retired orthopedic surgeon, and Dr. John Cumming, retired surgeon and critical care physician from, and also recently retired as the interim CEO of Hennepin Healthcare. So we'll have some good questions there. We'll also be taking questions from you. Use the chat function, which we all have learned, and just address it to all panelists, and we'll make sure we grab those questions. We'll hold those questions till the end. Our goal is to finish before 9 a.m. to give you some time to transition to your next meeting. Now, it is my pleasure to introduce Dr. Brent Asplin, president of VillageMD. I'm pretty excited about this. Brent has a history of being in the Twin Cities. Currently, he lives in Chicago, but he was also at Health Partners in Fairview. At Fairview, he was the president and chief clinical officer. So he has a good understanding of our marketplace and can answer some of our market-specific questions for those of us that are in the Minneapolis, St. Paul, and greater Minnesota areas. What caught my attention was the announcement of VillageMD doing a partnership with Walgreens to be the first national pharmacy chain to offer full-service clinics co-located in their stores on a large scale. They expanded their partnership to open 500 to 700 Village Medical at Walgreens, a physician-led primary care clinics in more than 30 U.S. markets over the next 5 years. I said, wow, that's very impressive. And it's obviously more than just minute clinics. And Dr. Asplin is going to talk to us about the partnership, but also about at-risk primary care is one of the components. So without further ado, I'd like to welcome Dr. Brent Asplin.
Thank you, Joe. Good morning, everyone. It's a pleasure to be here. It's like a little homecoming for me. In fact, this afternoon, I'll be driving up to the Twin Cities. We're going to spend the weekend there. We got Floyd of Rosedale up for grabs at the bank tonight, so it should be a good game. And I wish we were able to be together in person. However, obviously 2020 creates some unique challenges for us, but obviously it would have been fun to be together because I know there's some familiar faces out there in the world of Zoom. So it's Friday the 13th, and I just want to start out here. I got this on Twitter yesterday, and I said, you know what, I really need to start by sharing this particular tweet that I got yesterday. 99 problems and 86 of them are completely made up scenarios in my head that I'm stressing about for absolutely no logical reason. So I don't know if that resonates with you. But it certainly resonated with me. Yes, we got a lot of problems out there in the world today, but sometimes we make it a lot worse than it needs to be. So take that as a gift to start us off on Friday the 13th. I don't want to be too predictable, but obviously I'm going to start my prepared remarks this morning by discussing the Coconut Grove Nightclub in Boston, Massachusetts. In fact, it was almost 78 years ago exactly that there was a tragic event at the Coconut Grove nightclub on Thanksgiving weekend of 1942. Coconut Grove had been one of Boston's most popular hotspots. It was owned by Boston Charlie, a member of the Boston mob, until he was gunned down in 1933. And Boston Charlie's lawyer, Barney Walensky, took over Coconut Grove. And he ran a tight ship. In fact, he was so concerned that patrons would leave without paying that he covered up exits. He had one emergency exit bricked in. He had a revolving door at the front to make sure that everyone had paid their bill before leaving the nightclub. This was Thanksgiving weekend. Just into World War II, there were many servicemen and women back in Boston for the weekend. And in fact, that night, Boston College was supposed to have a big homecoming celebration at Coconut Grove, but Holy Cross beat Boston College 55-12 on the afternoon of Saturday, November 28th, 1942. And they canceled the event. The mayor was going to be at Coconut Grove, and he didn't show up. Nevertheless, in a nightclub that was rated for 460 people, there were over 1,000 people in the nightclub that evening. In the basement, there was a lounge called the Melody Lounge, and a soldier unscrewed a light bulb so that he could have more privacy while kissing with his date. Shortly thereafter, a 16-year-old busboy, Stanley Tomaszewski, was asked to put the light bulb back in, and he couldn't see exactly where to do that. So he lit a match, put the light bulb back in, and shortly after that, there were flames and smoke. Incidentally, the formal investigation did not blame the 16-year-old busboy for the fire. Nevertheless, the fire spread quickly through the building, and with over 1,000 people and exits blocked, as you can imagine, it was a tragedy. 492 people lost their lives that night at Coconut Grove. Two movements were started because of this tragic event. It really shocked the nation. And in fact, it led to two major movements. The first was a movement towards fire safety. So the whole concept was, look, we need to build buildings so that we can have rapid egress as needed and have fire safety interventions put in place so that this type of tragedy doesn't happen again. The second major movement that actually started as a result of this was burn surgery. It really became one of the major events that created the subspecialty of burn care and burn surgery. Many of the victims went to Mass General Hospital. Ironically, that night, Barney Walensky was recovering from a heart attack at Mass General. So he was not at Coconut Grove the night that this happened. So those two movements happened, burn surgery and fire safety. But I'm going to ask you to imagine for a moment, what if a third movement had happened? What if people had said, look, the only way that we can prevent this from happening again, yes, we should do fire safety. Yes, It's good to have a specialty focused on burn care, but we need to make sure communities have the resources to respond to fires. And in fact, we need a federal fire care program. We're going to reimburse communities on a fee-for-service basis whenever their fire department responds to an incident. We're going to create an international classification of fires coding system to make sure that that reimbursement is appropriate. No, that is not a 927.4 vehicle fire. That is a multi-axle vehicle fire with multi-unit response with major complications. If this had happened, community fire departments would be the #1 revenue source for the community. We'd have add-on revenue for training programs, and of course, we'd have to have an active fraud and abuse prevention program to make sure that communities didn't upcode when their fire department responded to events. Now, today we can say this sounds silly. Of course, Brent, this is ridiculous. I guess the only silver lining in this is that communities wouldn't need property taxes because they'd have their fire departments. You can step back for a second and say this could never have happened, but is it exactly what happened in healthcare? And in this scenario, not only would communities have their #1 source of revenue be their fire department, we'd have a lot more fire departments and we'd have a lot more fires. But what if hospitals use the fire department business model? Think about that. Highly reliable services, safe, effective for critical care, very complex or emergent conditions or procedures. Closely tied and connected to ambulatory networks that promote health and wellness and manage chronic conditions upstream. And everyone widely accepts that hospitals are absolutely a critical component of the care delivery system, but they're cost centers, not revenue centers. They're cost centers needed to support community health and wellness. And their success is defined not by how often they are used, but how seldom they are needed and how effective they are when they are needed. Now, look, it seems in some respects like this is an interesting thought experiment, but that's exactly where we are looking to go with at-risk primary care. We do not have a clinical model problem with our hospitals. We do not have a clinical model problem. Look at the amazing care they're delivering today in the face of this global pandemic. They're heroes. We have a business model problem in healthcare. And we've known it for some time. Now, some people say that there's no way we can make this pivot to treat hospitals as cost centers because we'll undermine innovation and we won't get the investment and we won't have the standby capacity we need clinically in the system. Well, I moved to Cincinnati shortly after leaving Fairview and lived in the community of Indian Hill, Ohio. There were 2 fire departments in that town. And during the course of my 3 years there, both of the facilities were completely replaced. There was innovation in the fire department system, despite having this business model that reflects it as a cost center. So I guess I would submit that treating hospitals as expense centers in service to community health and wellness will not undermine innovation. And in fact, that's exactly what we're trying to do in the at-risk primary care space. Paul Starr won the Pulitzer Prize. He published The Social Transformation of American Medicine in 1982 and won the Pulitzer Prize in 1984. And it's a history of the development of the American medical industrial complex. In fact, the subtitle is interesting: The Rise of a Sovereign Profession and the Making of a Vast Industry. It's an interesting book. And one of the key takeaways, at least for me, was that if you want to see the structure of the American healthcare system change the way you pay for healthcare. If you really want to see the system pivot, change the way you pay for healthcare. And so that's really fundamentally what I'd like to spend most of our time talking about today, which is how and will at-risk primary care change care delivery in this country. Yes, I'm going to spend time introducing you to VillageMD and talking about the partnership with Walgreens, but it's not just about VillageMD, it's about at-risk primary care. And the ground is moving much more quickly than you may realize in this area. So VillageMD was founded in 2013. Our co-founders, Tim Barry, Clive Fields, and Paul Martino. Tim had a background in technology and then worked for Blue Shield of California and then ran Medicare Advantage in Houston for Universal American. He met Dr. Clive Fields, a family physician in Houston, as Clive's practice was one of the highest performing at-risk primary care groups in the Houston market. And then later they met Paul Martino, who has spent decades prior to VillageMD in the payer sector. Why was it formed? They formed VillageMD because they firmly believe that primary care providers did not have the support they need to deliver the outcomes that they know are possible with the right resources, investments in the care model, and actionable information through data and technology. And there really was a need for an organization that was really solely focused on providing PCPs with the support they need to not only deliver better outcomes, but also lower the cost of care. So that's why VillageMD was founded. Currently, we're active in 10 markets. It's now around 3,000 providers that we're privileged to have a partnership with in 10 states, and we're serving 3 million patients across the country. So that's where we are today, and we're growing rapidly. The model is really focused on at-risk primary care and all the things not only clinically, but financially and technologically are required to drive at-risk primary care. We believe that in order to be successful in managing outcomes for populations, you need to be present in the community in traditional office settings. You need to be present in the neighborhoods where people live, and you need to go to the home and deliver full service primary care services in the home when needed. And so the model is designed to have the same clinical support across all these settings of office, neighborhood, and home. Most of primary care traditionally especially independent primary care, is a reactive care model. The door is open and we're going to see who raises their hand and says, today I need to be seen for whatever the problem may be today. And it typically does not have the infrastructure to get visibility to the population that's at risk, understand who is most likely to have a high cost event or an adverse clinical outcome, and then get out in front of that outcome with the resources and care management capabilities to drive a different result. So our goal is to surround the primary care physician and his or her care team with all the ancillary resources, additional care model capabilities, and actionable information they need to manage populations. Starting before patients come, not only looking at who has signed up for a visit, but also identifying what type of quality gaps need to be closed, what condition-specific interventions are needed, what diagnoses need to be redocumented in order for us to have the resources to care for that patient, but also driving visit frequency. Rather than just waiting for people to show up, being proactive, continuous, high touch, and driving people in for more frequent visits based on their overall risk profile. Within the clinic, providing information about care gaps in real time so the care team and the PCP can close those gaps. And then following up afterwards, not only to make sure that if something wasn't captured during the visit, that we pick it up after the fact, but also to provide support to the patient in the home and resources so that they can self-manage their chronic conditions. The platform we build this on is what we call DocOS, which is our technology platform that ingests clinical data from EMRs, over 65 different EMR instances. fully unredacted claims data, payer reports, lab data, pharmacy data, self-reported data, health information exchange, et cetera, and puts it into a common data model so that our workflow solutions can drive against the gaps that are present in the population to deliver better clinical outcomes. We look at this pretty simply. Most of this is about execution. It's not about the secret sauce or some a secret like the recipe for Coke, for example. It's really about execution for populations. And we think of it, we call it the quad, 4 simple areas: panel management, clinical documentation, quality, and utilization management. Panel management is really getting visibility to the population at risk and driving the frequency of encounters. Clinical documentation and quality are really that nature of in the cycle of pre-visit planning, gap closure during the encounter, and post-encounter review. And then our utilization programs are not only a multidisciplinary proactive care management program, but a post-acute reactive support program to manage patients after hospitalization or other events, and to manage all of the different interventions that could take place in the post-acute sector, as well as our in-home primary care services to support those who are either truly homebound or are at higher risk for complications by getting out there not only with mostly nurse practitioners, but also other care delivery components in the home. It's not traditional home care, it's primary care in the home. As mentioned, we stand this model up on our technology platform and have a combination of clinical and non-clinical resources to drive those outcomes. In the at-risk primary care space, there certainly are other players, and happy to talk about that as we get into the Q&A. We focus on all the patients. We want to be a partner for PCPs across their entire panel, not just high-risk Medicare. We want to be a partner across commercial, Medicaid, fee-for-service, and Medicare Advantage. We've been fortunate to drive results in multiple lines of business in multiple markets. We look for long-term relationships with our physician partners. We think that the investments required in order to begin to see results in at-risk contracts are usually on the 2 to 3 year time horizon before we begin to see the return in terms of performance in those contracts. And so we are looking for long-term relationships with physicians. I've mentioned DocOS, the integrated technology platform, which allows us to scale faster. And because we take care of all lines of business, we have greater influence in the markets that we serve. Here are some of the results. So I've been fortunate to drive better clinical quality outcomes, lower cost, lower inpatient admits per thousand, particularly for those with high-risk conditions. And some of the results are shared here. Most importantly, we're a physician-centric organization, a provider-centric organization, that our goal is to support physicians across their panel. And some of these quotes are really nice to see. Dr. Fessinger, it's in that reactive model. As he said, it was frustrating knowing the only way we made money and kept the doors open was seeing patients from the office, not actually doing all the other things that kept them healthy. And that's really what we're focused on. Earlier this year, in July, we announced the expansion of a Walgreens partnership that began with the opening of our first Village Medical at Walgreens clinic in Houston in November of 2019. We have 5 clinics open in the Houston area as we speak today. 4 more will be opening in the next 2 months. And 4 additional co-located clinics will be open in Phoenix in the next 2 months. And then we will have 40 in 6 markets by mid-next summer. And as the announcement shared, we will be opening 500 to 700 of these clinics in 36 markets across the country over the next 5 years. Why did this happen? Well, the conversation began with a discussion around Walgreens Take Care clinics and whether we would be interested in partnering with them to manage those clinics. Those are the small retail clinics that really have a limited scope of services that you've all seen. And after a discussion, we said, well, why not deliver a full service primary care model in the neighborhood where our patients live and work. So this expanded partnership, as I mentioned, will be 500 to 700 clinics. These will be physician-led clinics in the clinic. They really are going to take advantage of what we found in our co-located pharmacies that we own and operate, that the integration of a pharmacist into full service primary care really drives differentiated outcomes. When you walk into a Walgreens, you're seeing about 10,000 square feet, of which 1,500 square feet is the pharmacy. These clinics will be a third of the Walgreens. They're walled off, a separate space. You could walk in, see your physician or nurse practitioner, walk back out and never set foot in the Walgreens if that was your choice. They will be staffed by more than 3,600 primary care providers. I'm pleased to say that more than 50% of the clinics we've identified are in medically underserved or health professional shortage areas. And we'll be also delivering telehealth services from these clinics. You can have in-person care or a telehealth visit. And Walgreens has invested to help with this expansion, although I will add that they are still a minority investor in Walgreens, and management and the initial investors still control the destiny of VillageMD. But this is really about taking this clinical model, leveraging the opportunity of better clinical outcomes with pharmacy integration, and then bringing it to neighborhoods around the country. We have found much better results with the optimization of medication use and medication adherence in our co-located clinics. I don't think there's any question that greater involvement of clinical pharmacists, whether that's through a MedSync program or pharmacist consults, or the convenience of having a pharmacy on site and being able to pick up acute prescriptions without waiting, all those things will drive a better clinical outcomes and a better consumer experience. And our results, again, with the pharmacies that Village Family Practice own, showed similar improvements in medication adherence. And this is what we're looking to bring across the country through this partnership. So at-risk primary care, and we're going to transition to your questions here in just a minute, but what are we trying to accomplish, and why is it different this time? I know many of you may be thinking, look, Brent, we tried this in the 90s. It didn't turn out so well. A lot of groups took on risk. They were not able to manage it. Many provider groups went under in the 90s trying to take on risk. We had the backlash of against HMOs, and we kind of rebounded from that and went back to business as usual. Well, now we're at $3.9 trillion of spend in the healthcare system doing business as usual. And I'm going to argue that this time is different, and this time is different for a number of reasons, some of which are here on this slide. The first is that the clinical model for at-risk primary care, at least for Village Medical, is not a gatekeeping model. Our goal is not to stand between our patients and the care they need to get the best outcome. It's to get out in front and get them those resources in advance so they can drive to the best clinical outcome. Unlike the 90s, we can now tell a much more comprehensive quality and experience story. While none of us would argue that our measures are perfect, Minnesota's actually led the way in quality measurement. We now can tell a much better quality and experience story so that we can reassure populations that, look, yes, the cost of care was lower, but the outcomes were better. And having those metrics and being able to tell that story is really important. Today, the system is nearly completely wired, not 100%. There are still practices on paper, but for the most part, the system is wired. We could not have built DocOS in the 1990s. We have it today, and that actionable information is incredibly helpful. It does you no good to know that Mrs. Jones had 6 admissions for heart failure in 2019 on November 13th, 2020. It does you a lot of good to know that Mrs. Jones was in the emergency department last night. And oh, by the way, if you could get in on Friday afternoon to the clinic just to check in and make sure she's doing okay, it's much less likely that she's going to bounce back to the ER over the weekend and get admitted. Our risk adjustment is much better than it was. There's a lot of noise around risk adjustment, but the reality is the incentives in the 1990s were to avoid taking care of the sickest patients. And you don't have much of a health and wellness system if your care delivery system is looking to avoid sick people. Medicare Advantage is now growing very rapidly, is firmly established. It has bipartisan support. That was not the case in the 90s. And I can assure you there may be a lot of barriers. There may be a lot of challenges in an at-risk primary care environment, but lack of capital will not be one of them. And that may be something that is easy to miss when you're not looking at it every day, but capital will not be a barrier. They call it risk for a reason. This is not a straight line up and to the right business. This is risk, and there will be ups and downs, but capital will not be the barrier. So we often hear and the phrase, I'll believe it when I see it. I'll believe it when I see it. So I'd be interested as we transition to the dialogue now about what you think about at-risk primary care, this partnership with Walgreens, and what it means as we move forward. I actually think that I believe it when I see it is a little outdated. Sometimes you have to believe it in order to see it. And I believe that at-risk primary care is not only here to stay, it is going to change the business model of healthcare, I believe, for the better, into a more sustainable and sustainably affordable health and wellness system. So I believe it, and that's why I see it, and I look forward to the conversation. Thanks so much for having me. And with that, I'll pivot it back to Joe for some questions.
Thank you very much. That was enlightening, and I of course that tees up questions. I want to make sure I understand the model correctly. And let's say you go into a new market. Is one option that you develop a partnership with an independent medical group? Is that kind of the main model there, where you sign a long-term agreement and you bring your expertise to the picture and they sign a 30-year agreement?
Yeah, thank you. I want to emphasize that. So I'm glad you started there. We will always have affiliate partnerships. So if a physician wants to stay independent and come into the clinical model and work in the same contracts as our employed group, she should do that. And we want the docs to choose how they want to relate to the clinical model. The 30-year agreement is with flagship group if we were going to start a market together, right? So that's forming a company together. The typical PSAs, the independent practices that come in as affiliates after that would have shorter, but still what we would consider long-term agreements in the 5 to 7 year range because of how long it takes to drive results. Village Medical, we found, is not that old. Our employed group practice is now just under a year and a half old. We started it because we found that there were physicians in employment situations that wanted to come into a clinical model like ours, but didn't want to leave employment, go get a loan from a bank and start their own independent practice. And so that's one of the reasons we started Village Medical. So, and the Walgreens co-located clinics are part of our group practice model with Village Medical.
Very good, thank you. One more question, and then I'm going to turn it over to Tom, and we'll start the rotation. So what do you think this means for the large integrated systems that employ hundreds of primary care physicians? I mean, are you searching to partner with them, or, you know, how does that relationship work?
Well, I would start by saying it depends on what business model they're serving, right? And we need like-minded partners. We are not going to operate hospitals. We're never going to build a hospital. We employ very few specialists. We do contract our own specialists and pay our own claims when we're fully at risk. So we're interested in like-minded partners, both on the hospital side and on the specialty care side. And so it really depends on what the nature of the business model they're trying to drive. And if they're interested in driving an at-risk value-based care agenda, I think we're very interested in partnering with them. if they're interested in using the primary care platform that they employ to drive more and more referrals to hospital outpatient departments and to keep hospitals as full as possible, which, I don't think that's the case in the Minneapolis market for our health system partners, but it's certainly true in many markets around the country. Then yeah, it's going to be a competitive pressure for those types of systems.
Thank you. Tom?
Good morning. I'd like to add my thanks, Brent, for spending time with us this morning. Great information, and thanks for sharing your wisdom. And also thanks to our audience. We've got lots of great questions coming in. We'll try and get to as many of them as we can in the time allowed. Sort of synthesizing some of the questions from the audience, could you speak to how you decided to enter the 10 markets that you currently work in? And then project out, you mentioned you're going to be entering fairly rapidly 36 markets, I believe it was, in the near future. How do you choose what market to enter and what limits your future growth? You mentioned the capital isn't a problem. What do you see as being the main restraint to future growth?
Thank you. It's a great question. We've ranked, we can define a market as an MSA. We've ranked the top 100 MSAs according to what we believe would be good characteristics for our model. What are things that we look for? Generally speaking, a higher cost market is better for us than a low cost market. A fragmented market is better than a highly consolidated market. We like to see competition among payers and healthcare delivery organizations in a given market. So if a market is completely dominated by one payer or by one health system, it's less attractive to us. We like to see a market with Medicare Advantage growing because clearly this model does very well there. Although now with the new direct contracting initiative, which we will have in all of our markets with fee-for-service Medicare, that's really a synthetic Medicare Advantage for fee-for-service Medicare patients. So those are the characteristics we look for. Obviously, we all have a lot of relationships around the country, and some of these opportunities are, opportunistic. And then also Walgreens and us, we've sat down and really looked at what the best markets for us to enter and what those look like, at least over the next 2 years. And so we've mapped a lot of that out. So those are some of the criteria we use. And we look forward to being in about 36 markets over the next few years.
Thanks. What the second part of that was, what is the main restraint to your growth? Where do you foresee the challenges? If it's not capital,
really all about the doctors, right?
Personnel.
So it's about the docs, and it's about getting like-minded partners, their care teams, the APPs they work with that are really interested in an at-risk primary care model. You got to have a local practicing physician-led group. It cannot be a big corporate roll-up. It just doesn't work that way. And so I think our biggest barrier are the conversations with physicians who have owned their own practice for the last 30 years, or physicians who are in an employed situation and are not excited about it. Those conversations take time, and we got to build trust. And then we have to actually follow through by putting them in charge of being the stewards of the clinical model locally in the market. And that's what takes the time. It's much more important to have the conversations and get the right clinicians in the model than it is to just move as fast as these clinics can be built.
Excellent. Thank you. John, I believe you have the next question.
Yes. Again, I'd like to say thank you very much. This is really intriguing conversation. I have so many questions, and the panelists or the folks that are joining us have a number of questions that are really great. And I imagine we could be here all morning talking about this. But my first question really centers around you have these at-risk agreements with your primary care physicians, but again, in a population health, agreement or scenario, you have to take care of the whole patient through all phases. And how do you control or mitigate outliers, frequent utilizers of emergency departments, and other healthcare services where you don't have agreements with those providers? Is there ways in which you try to funnel your patients, or how do you manage inpatient and other things like that?
Thank you, John. It's a great question. It really starts with the data. If you don't have visibility, if you have 10,000 Medicare beneficiaries or Medicare and Medicaid beneficiaries at risk, if you don't know where those 10,000 patients are going, which ones are sick, and what types of events are happening, it's really hard to find out until after the fact, when it's too late to do anything about it. And so through DocOS, we bring in all the claims. Our ideal scenario is we will contract our own specialty network and have partnerships with hospitals. And then we really want those specialists. In some cases, when we go to full risk, we will even subcap specialists. So they're partnering with our PCPs around when they need to have a referral to a specialist. And then another big part of it is driving site of service to the most efficient site of service based on what the patient needs. And one of the biggest drivers of cost in the system right now is a hospital outpatient department billing for services that don't require clinically any level of care that's different than a freestanding bill, right? And we all know it. That and out-of-network billing are two of the major drivers of cost. And until you have all the claims and get visibility, you really can't mitigate either one of them. But listen, John, there's opportunity all the time. I mean, we have frequent emergency department users in our population, and we're not going to eliminate all of it. But the way the contracts work, as we get out in front of chronic conditions and drive more and more value over time, we're able to perform successfully on both the clinical landscape and financially in these at-risk contracts.
Thank you. Joe?
My turn. I'm going to ask a couple of financial ones or short questions that have come in. What's your MD retention rate?
We've had some retire, but our retention rate overall is over 90%.
Very good. Thank you. Your Doc OS system, does it integrate with Epic?
It does. Yes.
How'd you make that happen? I had to check. In terms of the risk, what percentage of risk can be adjusted for ahead of time is the question. And I think we're looking for, what is your mix of fee for service and capitation in your revenue? How do you accommodate that?
Look, most of the physicians we partner with when we begin the partnership are squarely in the world of fee for service.
Yep.
And one nice thing about all of this is that fee for service reimbursement is going to be alive and well the day every single one of us retires, whenever that is. We don't need fee for service reimbursement to disappear in order for an at-risk primary care business model to be successful. Most of the docs we meet are in fee for service, and then we want to understand their panel and then migrate over time. Our goal is to have that whole panel in some form of value-based arrangement. Not all of those are going to be global cap or global risk arrangements. Let's be honest about it. The commercial market, the commercial health insurance market right now is just not as predictable in terms of risk as Medicare Advantage. A lot of that is because it's ERISA self-funded plans, and that marketplace has not sorted itself out into an at-risk model that's predictable for providers who are taking risk. That said, we've had good success driving shared savings and improving clinical outcomes in our commercial contracts, and I would expect over the next 5 years we'll start to see commercial fully at-risk models begin to develop around and coalesce around some more consistency.
Thank you, Tom.
Thanks. Some of the questions have come in regarding the social determinants of health, which I'm sure, as you know, Brent, have really, I think rightly so, had a lot of emphasis placed on it. And the COVID-19 pandemic has certainly shined a bright light on the importance of the social determinants. Could you speak to how VillageMD incorporates the social determinants of health? One of our audience members astutely recognized that your ability to do home care may give you a unique window into the social determinants of health on an individual level. Could you speak to your response to that at the population health level as well as the individual patient level, if you would, please?
Yeah, you went to where I was going to go, Tom. I think it's so important to go to the home. And we do that with a number of different resources. I mentioned our proactive care management team. That's a multidisciplinary team of nursing, social work, and what we call resource coordinators. And the social work, most of the social workers are licensed clinical social workers. And we tie them to behavioral health resources in the community. Our resource coordinators are really designed to address social determinants barriers, such as transportation, such as affordability for both medications, supplies, or even food. This is a major challenge for sure, but the fact that we tie our in-clinic model to an in-the-home model helps us I understand at a much deeper level what those barriers are and address them. Would love to address more of the barriers. No one is going to suggest that we're addressing all of them. We can't, but we're absolutely getting visibility to them by being in the home. And I just don't think you can successfully manage the clinical outcomes and total cost of care for a population without getting into the home.
Thanks. A follow-up, one of the audience members asked whether those team members that are in the home doing the social services elements, are they employed by VillageMD or do you contract outside for those or a combination of both?
Mostly employed, but we do contract in some markets with some partners that will also go to the home or do other support. And then candidly, part of the resource coordinator role is to connect our patients to resources that are available in the community, right? So
Sure.
We may not provide all of the gap filling interventions that are needed, but we want to connect people to the resources that are available to them.
All right, great. Thank you. John?
All right, thank you. So, Brent, one of the participants asked, who is the paying or contracting customer of VillageMD? Is it employers, states, payers? Who's paying you? What's your revenue model?
Yeah, in the value-based arrangements, it would be whoever the insurance payer is. So that's CMS in the case of Medicare fee-for-service. That's CMS in the state in terms of Medicaid. Medicare Advantage will be the commercial Medicare Advantage carriers in each of our states. And then on the commercial front, same is true. We are developing models that will be able to go direct to employer. Currently, though, we work with insurers. And then we'll migrate those arrangements starting initially with some sort of shared savings arrangement or a P for P in terms of quality or care management opportunity. Then we'll go to shared up and downside risk. And then ideally, we move to full risk. And when we go to full risk, we want to be delegated for claims payment, for utilization management, for network management, for credentialing as well.
Got it. Thank you. Joe?
Question, how do you feel this model will enable patients to feel that they have a relationship longer term with their provider? Are you finding, that relationship is coming back? How do patients develop trust with these relationships? What's happening there? And are you finding patients switching health systems to join your care model?
We found that as PCPs move, whether that be moving from one employment situation to our model or moving from another group into our model or moving from one health plan to another, patients and members typically follow their primary care provider. We think that there's a strong allegiance there, and everything we do is to try to foster and strengthen that relationship. We're pleased that our net promoter scores this year have been in the low to mid 90s during the pandemic. We obviously pivoted, like everyone else, to virtual care. And then we use the care team and care management team as an extension of the primary care provider. So we always want to link back to that initial relationship between the patient and the PCP. And ideally, we're an embedded model. So our care management resources are in the clinic. And so we want to do a warm handoff with the PCP. And so all those things are designed to strengthen the relationship over time.
Thank you.
Brent, physician and provider burnout is a very hot topic in recent years, and I think, again, rightfully so. Could you speak a little bit to how your VillageMD model mitigates some of the factors that seem to be causing provider burnout?
Well, we've all been in meetings where people say, boy, if we just invested more in primary care, we'd have better outcomes and lower costs. And everybody kind of nods their head. And then we go back to doing whatever we were doing, which everything else but investing in primary care. So that starts there, I think, Tom, that what we're about is actually bringing the resources to PCPs that they feel like they're not on an island just trying to cure ills in 15-minute increments by whoever happens to walk in the door that day, but rather that there's additional resources, data, technology, and partners to get visibility to the population and get out in front and be more proactive about it. That said, there is no easy button. This is hard work. So I don't want to for one second to make it sound like, oh, we just have all these resources, so the PCP's got her feet up on the desk and the population's got amazing outcomes and the costs are going down. No, it's hard work, and burnout is a huge challenge, and it'll be a challenge for us as well. I just think that one of the major drivers of burnout is this gnawing tension that, I know I could be delivering much better outcomes for my patients than I am. I just don't have the resources to do it. And all I can do is keep my head above water. And you saw that in the quote from Dr. Fessinger that in the presentation. And what we want to do is pivot that to say, oh, you know what? There's an opportunity to actually get the clinical outcomes you always knew you could do if you had the right resources to surround you. And so that to me is one of the most encouraging parts of the model.
Good answer. Thank you.
Brent, I get the pleasure of asking the last question. So we'll try to take this forward. My question's kind of been, gnawing at me since I started researching your organization is really where are you headed? What's in the future for VillageMD? And do you envision continuing just the at-risk contracting model that you have in place, or do you eventually plan to acquire practices and employ providers and expand the clinical services that you provide, or are you going to just stay in the primary care at-risk contracting space for now? Where are you headed?
Sure, thank you. So for clarity, our Village Medical clinics, the providers are employed. So Village Medical is our group practice. And so we do have affiliates that are still independent. The Village Medical at Walgreens are employed providers in our group. We now have around 240 providers, 16 months into the group in 5 markets. We just announced this week that we launched in Atlanta. We're also in Austin, in Houston, in Phoenix, in Kentucky, and we'll be in 4 more markets within the next 4 months. So there is a rapid growth curve here. I think that we believe the environment is right to move at-risk primary care across the country in multiple lines of business, not just Medicare Advantage, but across Medicare, Medicaid, fee-for-service Medicare, and commercial. And one of the things that gives me so much confidence that this time it's here to stay is the nature of the conversations. I can't even describe to you, John, how quickly the landscape is shifting in 2020. In the middle of this pandemic, the phone is ringing, and we are having conversations all over the country with groups. I know other organizations in the at-risk primary care space are having the same conversations. Some of that is stress on independent practices due to the pandemic, and they're interested in potentially an acquisition. If for some of these practices, their current choices are to either shut the door or be acquired by a health system in the local market. Those are their two options. And so I think they're interested in organizations like ours to create a third option. There's also interest in health systems in terms of on both the system side and on the physician side. Let's face it, if an integrated delivery system is really focused on just driving fee for service, I haven't talked to a lot of PCPs that are very happy, because they're the stepchildren of that model. It's like, just feed our specialists and feed our hospitals, and please don't make too much noise. Thank you. Right? That is the reality. And we are going to employ a lot of those PCPs. And we're not very concerned about restrictive covenants. So it just is what it is. At the end of the day, primary care is needed. And I don't think a lot of courts are going to say, yeah, no, you can't practice medicine anymore, primary care doctor, when we're facing a major shortage of primary care physicians. It will happen in some markets, but not very often. Now, on the other side, we've had very successful partnerships with health systems that have said, you know what, we're really not in the primary care business. Let's partner with you. You can manage our primary care docs, and they've done very well, and the PCPs have done well. So that opportunity exists also. I just, in closing, that whole, I believe it when I see it, I believe it when I see it. I'm sure there's some people thinking, yeah, okay, I believe it when I see it. Sometimes you got to believe it in order to see it. And this is very different, and it's palpably different. It's exciting. It by no means is success guaranteed. We're going to stumble and make mistakes, but if we treat physicians and their care teams and APPs with respect, and look for like-minded ones that are really interested in doing something different, I'm convinced that at-risk primary care is going to be successful. Really appreciate the opportunity for the conversation this morning.
Thank you very much. Boy, I could keep asking questions. I'm sure other people could too, but we should maintain our schedule. So thank you once again. Thank you, John, Tom, for your assistance here. And a call out to Clifton Larson Allen and Frederickson Byron for helping us pull together this series. It was very intriguing, insightful, and I'm sure you're going to hear back from some of the participants about more about your model. So thank you very much. And don't forget about next month's December 11th session. Goodbye, everybody.